Hi, I'm Debbie Chang. I'm an undergraduate in the College of Arts and Sciences studying political science.
Hi, everyone. My name is Ralph Pietrafessa, and I'm a basic scientist in the School of Medicine. I'm pursuing a Master of Public Health and Bioethics and a Master of Science in Social Policy.
Good afternoon, everyone. My name is Dr. Jessica Striplett, and I'm a pharmacist who's currently pursuing a Master's of Public Health degree. So today, we will give you a quick overview of the problem that is facing with many of the citizens of Philadelphia and across the nation. They're facing it right now. We will then breathe life into our program, Algorithmic Care, and then finish up with our funding and then the timeline to initiation. Medicaid is currently the largest health insurance program in the United States. Roughly 1 in 5 Americans and 1 in 3 children are enrolled in this program. It was created with the intent to reach out to the individuals who fell through the cracks of the private health insurance system. It empowered these individuals with insurance and gave them the access to quality health care and the choice to be healthy. Medicaid, as it currently stands today, cost the U.S. government $415 billion in 2012. $415 billion, to understand this figure, will buy each member in this room and the entire U.S. population a MacBook Air. This may be the correct amount to insure these individuals and empower them with insurance. However, as it currently stands, only 5% of these individuals cost Medicaid more than 50% of its total cost. Therefore, 5% yields 54% of Medicaid's cost. This may be the correct amount, as I mentioned. However, only a small percentage is causing more than 50% of its total cost. And therefore, that we need to address this issue to see what we can do in helping these individuals. These individuals are utilizing so much of Medicaid's costs because of poor health, social isolation, environment, and other environmental and social factors such as mental illness. To bring it locally, almost 20% of admitted hospital patients in Pennsylvania were Medicaid patients. And in 2012, there were about 265 recorded hospital admissions, but only about 178,000 Philadelphia residents were hospitalized. One way to explain this discrepancy are due to these superutilizers. These superutilizers are due to poor health. In order to fully address poor health, we must consider the factors on the left side of your screen, such as housing insecurity, mental illness, lack of a medical home. According to Dr. Osh in his New England Journal of Medicine article, healthcare accounts for only 10% of an individual's overall health. With housing insecurity, mental illness, and the other factors listed here and many more account for 90%. To paint the picture even more, over 1/3 of Medicaid superutilizers struggle with mental illness and substance abuse problems. Individuals lacking these long-term care models are the reasons why they're frequently hospitalized. Because of the high percentage of Medicaid patients are mentally ill, and mental illness being one of the many social, behavioral, and environmental factors that are causing this overall poor health, ARC, Algorithmic Care, will be addressing this population. To summarize the problem even more, as a full picture, poor mental health plus frequent hospitalization leads to high healthcare costs. On average, 1 day spent in the U.S. hospital costs us about $2,000. And in order to address this concern, we must go to the root cause, which are the social, environmental, and behavioral health. ARC, Algorithmic Care, is our solution to this problem. Overall, our program would use an algorithm to identify these superutilizers, and then superutilizers who are mentally ill patients. And then these high utilizers will be linked with community behavior health, which is CBH, and overall that would reduce health costs. Once these these individuals are identified, CBH will address these environmental, social, or behavior factors that are leading these individuals to having poor health. Let's focus on the algorithm. The algorithm will incorporate data from CBH, Community Behavior Health. Community Behavior Health we'll also consider their data with these managed care organizations, Health Partners and Keystone First. So you ask, why do we need to get data from all these sources? And the reason why, in the state of Pennsylvania, Medicaid claims are divided into two components. One, behavior health, and the other one, physical health claims. These two components are not housed together. And then as Dr. Matt Herford from CBH mentioned, there's a need for both of these components to come together. And when they're coming together, then we can accurately address these super utilizers. And that's why we're here. Through the algorithm, we will consider the behavioral portion claims through community behavior health, and then we will also consider the physical health claims through Health Partners or Keystone First. Our program will also evaluate the progress of using the algorithm and then linking these super utilizers to CBH through a paired analysis, which will last a year. And then the data will be researched and analyzed by a biostatistician and then also a research coordinator or data manager. Our stakeholders. We have been in communication with Dr. Maria Raven and John Billings. Dr. Maria Raven is the author of the program that was initiated in New York City, and John Billings is the individual who developed the algorithm for Dr. Raven's program. Through the help of Dr. Raven, we contacted John Billings so we can go ahead and tailor the algorithm that's already created to our population. We've also been in contact with CBH, Community Behavior Health, and through their services, we will be able to address the needs of the environmental, social, and behavioral needs that these super utilizers would require. Our overall budget is $76,000. The software of the algorithm is only $500. The software is a statistical software, and then to use a data analysis will cost us $25,000, and a research coordinator will cost us $50,000. Fortunately, CBH currently has all these resources. Therefore, through their collaboration, ARC, Algorithmic Care, currently has no expenses. Now, through the process, so as I had mentioned right now, we have currently no expenses, but if we do start to realize that we have expenses, we plan to apply to the Robert Wood Johnson Foundation and then the Commonwealth Fund by April 2nd. April 2nd is the deadline for the Robert Wood Johnson Foundation. Robert Wood Johnson Foundation and Commonwealth Fund are the two organizations that funded the New York City pilot program, and that's the reason why we targeted these two organizations. So as a quick timeline, ARC will apply for the necessary funding by April 2014, which is the deadline, as I mentioned, of Robert Wood Johnson. We plan to complete the algorithm components by June 2014 and implement the algorithm by late summer, August. Due to the affordability and the feasibility of this pilot program, we'll be able to initiate this program by this summer. ARC, Algorithmic Care, is all about prevention. The best way to decreasing the medical cost is by targeting the process before the money is spent. Thank you.
You mentioned that New York and Chicago are two models that you see in place. And I'll borrow something that Mark just said about the ability to implement that here. What do you see the challenge in the ability to implement that here in Philadelphia, looking at New York and Chicago?
Okay, so what was happening in New York City and Chicago is they were identifying patients on site in hospitals and then getting them the human services that they needed. What we're doing is not quite the same. We are not identifying people within hospitals. What we're doing is we're partnering with CBH and other managed care organizations to combine the data so that CBH can identify patients more effectively and help those people in their system. Because what's happening is how CBH currently identifies superutilizers is they look at their data and they look for people who have been hospitalized 3 or more times in the last year. And with this algorithm that's already been developed by Dr. John Billings, that algorithm will more accurately identify the superutilizers with the physical claims data and the behavioral health data.
Also, to emphasize the challenges, is that in New York City, you know how I mentioned how Medicaid has 2 components, behavioral health claims and physical claims? In New York City, they're together. So then the challenge for Pennsylvania is that they are in 2 different locations. CBH has emphasized that they have the behavioral claims data, and then they're identifying their superutilizers by just this data. So, but therefore, there's a need to address the full overall health of the individual, and then that's why they need that physical data. So there was the challenge, but through this algorithm, when we incorporate both of these components, we are able to accurately identify these superutilizers.
And why do you think that this didn't come up before here in Philadelphia, Pennsylvania? I mean, why didn't somebody else come up with this idea? What exactly has been the problem here?
I think the answer to that question is that there's never been an opportunity posed with someone already has an algorithm developed that can identify these individuals. So let's see if we have an appendix. So this is really what Jessica was talking about, is you have this sort of, there's not a single repository for where all the data is housed. Behavioral health data is housed by CBH. The physical health data is housed by those 5 managed care organizations. But of course, you have individuals that have complex chronic conditions that have mental health, a behavioral health component, but also a physical health component. And these are the individuals that are in the overlap that are really slipping through the cracks. And CBH does not have the tools or the algorithm or even the data, because they don't have the physical health data to identify these individuals.
Can I just interject here, because this is a very painful conversation, but it goes to what Dwight just said. I was the person who made the decision to carve out mental health from physical health at the very strong behest of the mental health community, who wanted their own thing. And I'm not saying that that was not the right decision at the time, but the observation I would make, going to Dwight Evans' comment, is that there has been a requirement in the Medicaid program since day one for case coordination, sharing of information, using drug data, which is the data that both sides see the most easily. And these institutions seem incapable of creating a systemic method for case coordination. So I absolutely believe this. I wanted to see this happen. I hate to think how many years ago it was now, but I think the institutional barriers to getting these organizations to work effectively together is a much bigger problem than an algorithm. And it has to do with just them all being bureaucracies of different kinds, as well as some very perverse sorts of financial incentives as to who's writing the drug script, who's paying for the hospitalization, who gets the savings, if there is savings from lack of hospitalization. They're very knotty problems, and frankly, this is a city where people don't like to play together. So I would just sort of echo what Dwight said. Of all of the proposals, this is the one that, if you could pull it off, would have the greatest financial impact in the Commonwealth, in the city, and nationally. But I think the algorithm is not the issue, nor even the data sharing. It's making them do it once they know who those folks are. So it's really a discouraging, I think you've tackled something big, for sure, but I'm much less, I just don't think there's a sword that will change behavior that's been entrenched for at least 20 years that CBH has been around. You can fight me on that.
Yeah, I actually want to just discuss it because I'm learning. You know?
That's a very good response. Nicely done, nicely done.
One of the so you're saying that it's the behavior of these different organizations. They don't want to work together in order to address the superutilizers. And
I don't say they don't, I'm just saying they don't want to. I don't think they, in the end, will.
in the end will. And when we were at the meeting with Community Behavior Health, CBH, there was an individual by the name of Martha, and she is the one who's in charge of superutilizers. So she was very interested in her idea. And she said that monthly she had meetings with these managed care, there's 5 big ones, these managed care organizations. And through these meetings, they talk about how to address these superutilizers. And my group will correct me or not, she did say that the way that they figure, their approach now is by targeting, if the individual's been hospitalized 3 times, then they're going to deem them as superutilizers. However, as you can see, that there's a lot of loopholes with that. And when she was talking with us, and we were in a group of 6 other people from that organization, they're saying that they've already been in collaborations with these organizations. They've been trying to work at doing this. The only thing they're missing is that they need where our program comes into play, where we would be more of a consultant between these 2 individuals. Because yes, we're the algorithm, but we're also housing the data from these managed care, from Health First, for example, and housing the data from CBH. And even at the meeting, CBH, the individual Martha, and their program evaluations individual said that they will give us the data. So once we have the algorithm, they'll give us the data. Once we can put these data together, then we can define these, we can help these identify these superutilizers. So now the next question is that are they really going to help these superutilizers? And the first thing I asked them in the meeting, I said, wait a minute, there's going to be a large pool of individuals coming to you now. Are you going to be able to address all of these individuals' needs? And they said that these individuals, they always encounter them eventually, these mental health individuals. They always encounter them individuals down the road. But by the time they count them, they have a lot of problems with them, not just mental health, but they have housing insecurity, to the point that mental health is not their main concern. So they want to identify these individuals before all these heavier problems come into their space. So they're saying that if you can give us this algorithm to address them earlier, so then our algorithm would house both data, then we can do what we do already in helping these individuals.
I want to commend you because I think you had one of the hardest jobs today, because I think if you look at the other proposals, it's really clear to see how they're touching people's lives every day, kind of a high touch. You're talking about data and an algorithm, right? And that's hard to make that sexy, right? So I think that you did a very good job on that issue. I don't think Feather's comments are a criticism. I think because I think I had a very similar reaction to it. That is, you might want to incorporate a change management aspect to what you're doing, because this is a lot more than just an algorithm. It is that sort of cross collaboration that is required. And Feather and Dwight are exactly right. We don't play in the sandbox well together across, even if they begin to in the very beginning, because everybody's kind of around this initiative. That stuff kind of breaks down, and it's often personality based, and when personalities leave, you're back to square one. So creating those processes kind of around how people collaborate may be something you want to incorporate into your solution that I think makes sense. In addition to that, I think one of the things I think you have to do is to bring it to life through someone, through one of those superutilizers, and how they had a clear benefit based on kind of what does the end game and the success look like when you're because I think it's harder for you, because it's easy to show how we're going to impact kids on youth violence, right? It's easy to show how we can mentor kids to get them to go to college. For you to I think you have to figure out, going back to I'm a recovering lawyer. back to that trial lawyer from many years ago. I think you have to figure out how to tell that narrative in a way that brings the algorithm and the data to life in a way that impacts a real person's life. But besides that, I think you did a great job.
I guess I'll, follow along this line of questioning. And I was glad you put that Venn diagram up there because it's very helpful. I'm not even sure, and this may just be that it's not getting over the lights to me, so this could be a me thing, not a you thing. But I'm not even sure you guys are really talking about an algorithm, right? There's a version of what you're describing that is a unique case identifier and an aggregation of 2 data sets that allow you to match total costs by person, right? And that wouldn't really be an algorithm, right? That'd be a data link that would be very useful and that absolutely sets up some of the line of questioning here about now, how are we going to change our interventions in those particular individual cases that now that we know, we can answer in Pennsylvania the 5% to 54% ratio that we can do in the national data for the Medicaid program, but we apparently can't really do here. And that's worth knowing, right? Worth understanding the relative incidence of the cost by individual cases is a super important data link. But a real algorithm, and it may be what you guys are also after, I'm just not sure, a real algorithm lets you take what you do know and make really good guesses about what you don't know, right? And so if what you're saying is that this algorithm could link these data sets and using the CBH and the physical care data, make predictions about the risks to, say, housing insecurity, that would be useful. But does your algorithm propose to go that far?
Yeah, so that's actually something that maybe, I guess, wasn't clear in the presentation, is that this is
It's a
not
me
only
thing.
a case-finding algorithm, it's a predictive algorithm. So just looking at this diagram, we're going to identify individuals at a reference admission into the hospital. We're going to look at that past 3 years of medical claims data, both physical and behavioral health, if we can combine the two. Once we have identified those individuals at the reference admission, this is all going to get pooled into a statistical program. We're going to perform a logistic regression where we have hundreds of variables that all have binary outcomes. So hypertension, yes, no. High cholesterol, yes, no. Heart disease, yes, no. Cancer, yes, no. Hospital admission in the past 90 days, yes, no. And based on those parameters, they're going to be assessed a risk score. And that's going to range anywhere from 0 to 100. And this really allows us to predict into the next 12 months whether or not these individuals are going to return to the hospital. Because one thing they find is with these predictive case-finding algorithms, it's very easy to see who is a high utilizer in the past.
Right.
But it's very hard to predict who will be one in the next year because so many parameters change. So once we have a risk score, an individual risk score for these Medicaid beneficiaries, anyone that's above a 50 will be identified and CBH will directly intervene at that point.
See, that I think is I'm sorry, you get in there. I mean, I think that is a very powerful partial response to Feather and others' questions, because, which I didn't hear, when you guys were having your discussion, not fight, which was very nice. But that starts to create an interest in the implementing agency, right? And that's, you guys need to get that out there, I think. You want to lead with a little bit more of that content.
Yeah. Thank you.